Action. All right, you guys, Mr. Median here, Mr. M, and we're back here for another video. And again, you guys, we're getting a lot of requests, so we're going to try to do as many as we can. But it's all about my production team too as well. They're in clinical, so they got you guys can be done in December, right? Okay. All right, so they got a few more months, and then maybe once they're done, if they have some time, they're not too busy making a lot of money out there being a rat tech, they can help me still do some more videos. All right, so. But we're doing AEC, everyone's favorite, automatic exposure control. So the number one thing that you got to know about AEC is exactly what it stands for first, right? So we're going to put here automatic exposure control. Okay, so number one, that's what it stands for. Sometimes they just ask you what it stands for, but again, you know, on the tests and quizzes, they're going to ask you other things. So what exactly is it and how does it work? I personally, as a tech, I guess I have some control issues because I turn it off. I turn off AEC, I turn off PBL. When I was doing MRI and CT, I like to do my own protocols, you know, as long as they met, you know, alignment with the radiologist, what they wanted. But I like to be in control when I'm doing the imaging itself. But automatic exposure control is a great feature. It allows us to go ahead and get good optimal quality images at the right exposure. All right. So again, I personally don't use it, but I'm going to tell you exactly how they work. I'm not saying that I haven't used it, but again, I just turn it off. Okay. So AEC, what is it? Well, it's using technology by the detectors, not the detection system of like the IR, but there's the detectors that receive the signal as the signal goes through the part. And once these detectors become saturated with energy, extra energy, it terminates exposure. So one thing about AEC, as a tech, you lose the ability to select mass. So as a radiographer, you no longer can select the mass. Why? Because with AEC systems, the only thing that you can set is MA and KV. I'm going to put that here only. So again, you lose the ability to select the mass. So mass is MA and time, correct? So that's exactly what you're losing the ability to do is select the time, but you're letting the system, the automated system, do that for you. And again, it's all based upon the part thickness, the size of the patient, and if the patient's condition, like certain pathologies, we'll talk about that. That's going to impact AEC, automatic exposure control. But what it uses two types of technology. It used to use what's called photo timing devices, photo timers. Now, photo timers, this is what it started off with. Now we're using mainly ionization chambers. Some of the newer systems are using solid state detection systems, like we use in CT as well. But the photo timer, what it did was, let's say we had X-ray energies that were going through the object, which is the part, and our patients are always happy, right? So then it would go through your grid, your let's say wall bucky here, and then it would hit the AEC device, and then you would have your IR right here, okay? So as it goes through, when it hits the AEC device, if it was a photo timer, what it would do is it would hit an area of cesium iodide. Now, what do you know about cesium iodide? What type of material is that? It's a scintillator, right? So the cesium iodide, X-rays would hit it, and then it would produce light. All right. So then the light would saturate that device, and then it would terminate the exposure. All right. So photo timers used to use a scintillation system. I'll put it here, a scintillator, X-rays, right, would hit the scintillator. It would produce light. The light would send an electrical charge in that device. The charge would occupy it, and then it would fill it up to the point where it has to stop it. All right. Some of my students have analogies of a glass being filled with water. You know, once the water is full in that glass, then there's no more. It's going to stop. You can't pour any more into that, right? Okay. Ionization chambers is normally what we use now. So we have X-ray energy, X-rays, that are going to go ahead and go through the part. Okay. Again, this is our patient. They're happy. It's going to go ahead and hit the grid, and then it's going to hit the AEC system. but this time we're using ionization chambers, and then here's your IR. Now with the ionization chamber, it's going to go ahead and hit a gas that's filling the chamber. And once the energy hits the gas gets excited and it creates a charge. And once that charge occupies that space, then again, it terminates the exposure, okay? So again, we're working with two types of technologies mainly. Phototiming is kind of like where I started with, I'm not gonna lie. And then we use ionization chambers. I think some of the newer systems use solid state detectors, but I don't think it's in the reading material that you guys have too much. But again, it is systems that are using detection systems to terminate the length of exposure. So I'm going to draw two patients right here. Okay. All right. So we have two patients. They're both happy because our patients are always happy. So as the x-rays go through the system here, you guys, or go through the patient to the system, think about it. All right. This here, you guys, this patient that's smaller, what's going to happen? The x-rays are going to go through that patient quicker, correct? So what's going to happen to the time? It's going to go down. So as the part gets smaller and thinner and is more radiolucent, the x-rays are going to go right through. Your exposure time is going to be less. All right, so this one's going to have less exposure time. All right, now this one here, this one's going to have more exposure time, correct? Because it has to go through the part. And as it goes through the part, it's going to get attenuated. So, you know, it's going to wait for more x-rays to go through it. So it's going to keep zapping those x-rays to go through that patient until it hits the system. And then it says, stop. We're going to stop it. So some people have said, but Mr. M, what if the system keeps going? Well, that's where you have backup timers, okay? So there are backup timers with these AEC systems. So backup timers are preset, and they're usually about 150% of the anticipated mass. So let's say you're going to do a lumbar spine. Well, then let's say you're going to use 40 mass for the lumbar. Well, you wouldn't exceed 150% more of that amount of 40 mass. So backup timers are usually set at 150% of the anticipated mass. It cannot exceed that, or it can't go past 600 mass. Now, if you're using 600 mass, something going on, right? So again, but this is the backup timing system. Now, how exactly does it work in terms of configuration? Well, I'll tell you, if I was going to do an x-ray on me on my chest, all right, that's a terrible IR, huh? All right, let's do it again. All right. Let's say you're going to take an x-ray of my chest, all right? And you had these little squares that look like this. Well, what you would do is these little symbols are representing where the detectors are. All right, so your ionization chambers would be there. So if you're doing a PA chest, you would go ahead and let's say you had APR, and you have the APR system, the automatic or anatomic program radiography, and you hit AEC. If you would hit PA chest, it would automatically activate the upper outer chambers for you. Okay, so you would go ahead and put my chest against the board, tell me to breathe, you would x-ray it, and then the exposure time is not going to show up until after you do the exam, okay? So sometimes the chambers are automatically selected, and sometimes you have to select them. It just depends on your system. Sometimes you can override them as well, but the chambers are going to be in the areas that you're putting the area of interest, all right? So now if I do a lateral chest, let's say I do a lateral chest, well then we're only going to go ahead and use the center chamber, just like this here, okay? So it's very important to place the area of interest over that chamber, because if you're off alignment a little bit, then it can really cause the image to be overexposed or underexposed, and that can have an impact on the patient as well, right? So let me give you an example. I'll give you an example, because one of my students just recently said, Mr. M, I did this lateral C-spine, and I used AEC, and the image was underexposed. And I said, well, can you send me the image? No patient information, of course, right? I said, send me the image. And when they sent it to me, you guys, what I noticed was that the centering of the C-spine was off a little bit. The C-spine was not lined up over the chamber. And what happened was, you guys, it was underexposed. The image was underexposed. And I was trying to explain to them over the phone, of course. Well, you know what? It looks like because your C spine was more over here, so the vertebrae were more back here. So guess what? The x-rays went right through and hit the chamber a lot quicker. So the response time said, hey, I'm done. And it cut off the exposure. So they ended up having, you guys, underexposed vertebrae because they didn't allow the object to be centered over the chamber, and that caused it to be underexposed. All right. So that's one incident. And there's another incident, you guys, that I've read in a book. I haven't experienced, but if you were to use a gonadal shield and you put the gonadal shield, let's say you're doing a pelvis and you happen to put the shield over the chamber by accident, the area of the chamber, then what's going to happen? The x-rays are going to go ahead and become attenuated by the gonadal shield, and the detector is going to be like, hey, where's my x-rays, right? And before you know it, the system's just running x-rays and running x-rays and running x-rays. And before you know it, you've overexposed the patient until he hits the backup timer, right? So again, if you cut off the chamber with the lead strip by accident, then it can go ahead and cause an overexposure, all right? Now, the other thing is pathologies, and this is why I don't really use AEC systems as much as I should. I know how to use them, but the system doesn't know how to accommodate for pathologies. So if you have, it's a patient with congestive heart failure, and you know that in advance, you would have to hit the plus density button. You would see it. Okay. So sometimes you see these buttons like this. Well, when you hit the plus density, you're increasing the exposure time is going to be about 25% more. Okay. So it'll be 25% more that's going to be required for the exposure. If you have somebody that has, let's say, COPD, then you would hit the negative button. And you guys, 25% is just on average. It can be from 20 to 30%, just depending on your system. But the plus density, minus density buttons are going to be designed to help you with patients that their body habitus or the pathologies, you guys, that the system doesn't know how to accommodate. Okay, so that's how you would use these. Again, you guys, AEC can be a wonderful tool if it's utilized correctly. But I tend not to want to use it because I know I'll get lazy. I want to be able to set my technical factors manually. This is where I know the fixed KV or the variable KV techniques. We had videos for that if you want to see that. But again, I would select the technical factors as a manual setting for myself, and I encourage you guys to learn the manual settings as well. Again, we were talking about film-based systems that we used to use, and we couldn't window it. You know, whatever you got with your film, you couldn't window it. You know, you had to learn your technical factors. But anyways, going back, I'm hoping that this will help you guys when it comes to different body parts. Again, the body part that you put over the chamber is the primary area of interest. One of the things that people struggle with are the obliques of the chest. So just keep in mind, if you're doing a LPO, the left lung is the area of interest. So you turn on that chamber behind that person on the LPO here. You turn on this chamber. So I'll show you really quick. So I've seen this on the quizzes and tests that I give my students. So let's say you have 3 chambers. If you're doing an LPO, you're going to go ahead and turn on this chamber here. Okay. If you're doing an RPO, right, RPO, this one here, then we're going to go ahead and turn on that chamber. So again, it's the area of interest. And this is the thing that trips up students sometimes when you're doing the PA obliques. When you do the PA obliques, remember, you're doing an REO, but what's it for? The left lung. So you're going to turn on that left upper chamber. All right. So again, it's the area of interest. If you go ahead and do an LEO, you're going to turn on the right upper chamber because it's for the right lung. All right. So little things like this, you guys, are going to take repetition. Again, study the heck out of these things. Read the book. Go back to the book. Again, if you have any questions, try to shoot them my way, and I'll be happy to try to help you if I can. Okay. All right. Thank you, guys. Hello everyone, you guys. Thank you very much for watching the videos. I'm hoping that they're helping you out. Please make sure that you subscribe and that you hit the notification bell to be notified about new videos. Again, remember to be good to yourself and be good to others. Thank you.